Hi guys, in this video let us discuss about CNS case proforma, central nervous system case proforma in general medicine. So anyway, you have to start with the patient details like name, age, sex, occupation, address and the handedness. So and so patient of 47-year-old, wife of, like if she is a female, wife of Ramesh, housewife by the occupation, hailing from Ramnagar, educated up to 10th standard, belonging to the lower socio-economic status, who is a right-handed, came to the OPD with the chief complaint of weakness. So mainly the chief complaints will be the weakness, deviation and any difficulty in the speech. So any weakness in the right upper limb or the right lower limb, or left upper limb or the left lower limb since how many days, and then deviation of the mouth to the which side, that is left side or right side, since how many days, and difficulty in the speech since how many days. So this will be your chief complaints. So then you have to go with the history of presenting illness, and you have to say the patient was apparently asymptomatic or patient was apparently well these many days back and she could perform her regular daily routine activities, and then she developed on which day, on at which time, like for example on 20th February at around 8 o'clock in the morning while she was walking, she felt sudden weakness in the upper limb and the lower limb. So you have to tell like that. So you have to say first patient was apparently asymptomatic, then she developed weakness. So you have to explain like inability to use the limbs, inability to use the upper limb and the lower limb, which limb, right or left, and then weakness. If it is sudden or insidious in onset, then go with the duration, then severity, whether it is paralysis or complete paralysis. Paralysis is a partial weakness, paralysis is a complete weakness, that is power is 0. Then you have to say about the progression. If it is chronic, you have to say which limb is affected first, whether it is lower limb or whether it is upper limb, and what is the time interval taken between the two limbs. And then you have to say whether the disease is static, whether it is progressive, worsening or improving. So normally the embolic strokes will resolve very soon, so there will be improving, and coming to the thrombotic stroke, it is a stroke in evolution. So the deficit is not maximum at the onset, it will be maximum while it progresses. So thrombotic will be stroke in evolution and embolic will resolve very fast. Okay, then hemorrhagic is not like it is in between. So you have to say whether it is static, whether it is progressive, worsening and improving, and you have to say whether she could use her proximal limbs and distal limbs in the affected upper limb on the lower limb. So if proximal limbs are affected, she couldn't comb the hair, she couldn't take the food to the mouth. If distal limbs are affected, buttoning the shirt, mixing the food, she can't do these activities. And in the lower limb, if the proximal muscles are involved, you have to say whether she can do the squatting position or any getting up from the squatting position, any difficulty in getting up from the squatting position, you have to ask like that, and any difficulty in climbing stairs up and down. And in the distal lower limbs, slipping of chappals and the gripping of the toes, so you have to ask like this. And then whether the neck is affected, so you have to ask any difficulty in lifting the head off the pillows, and whether the trunk is affected, any rolling over the bed, any difficulty, and any getting up from the bed difficulty, any difficulty in breathing because of any paralysis of the respiratory muscles, and whether there is any diurnal variation. If diurnal variation is present, it could be some neuromuscular junction disorder like myasthenia gravis, where it is maximum in the early morning and it recovers by the evening. And whether the limbs are flaccid or whether they are loose, stiff or hard, like in upper motor neuron palsy there is hypertonia, no, and in the lower motor neuron lesion there is hypotonia. So you have to ask whether there is associated heaviness. Anyway in the exams will get UMN palsy, LMN palsies will be kept more in the PG level. So in the UG level we will get only the upper motor neuron palsy, so there will be associated heaviness in the limbs. So you have to explain in the history of presenting illness, first the patient was apparently asymptomatic, then you have to describe about the weakness, whether she is able to use her upper limb and the lower limb, any inability to use, and if it is present, then how it is, how is the onset, then duration, any severity, progression, and then you have to say what activity she couldn't perform, and whether the neck is affected, trunk is affected, any diurnal variation, any difficulty in breathing, whether the limbs are flaccid, loose, stiff and hard, you have to say about this. Then you have to go with the spinomotor system, like any wasting or thinning of muscles, you have to ask any pain, fatigue, muscle cramps, any fasciculations, muscle twitchings, involuntary movements. So this will rule out the element type, and extrapyramidal also will get involuntary movements. So we have to rule out the spinomotor system. So the weakness is all about the UMN lesion, and then in the spinomotor lesion you will ask for the wasting thinning. These are all about LMN history. low motor neuron history. Here in LMN the muscle involvement is more, so there will be the wasting of muscle, then the weakness will be present. So in LMN you will have what weakness will be preceded by the wasting. So wasting is more in the LMN lesion. So you have to say about wasting, thinning, pain, fatigue, muscle cramps, fasciculations, muscle twitchings, involuntary movements. Then you have to go with the sensory system, any sensory deficit, like whether he is able to feel the clothes, feeling hot and cold water while the bathing, any numbness, pins or needle sensation, sensation of walking on cotton wool. Sensation of walking on cotton wool is seen in the posterior column lesion, like any tabes dorsalis. So you have to rule out. Then any root pain, neck pain, back pain, any band like sensation, girdle like sensation. So these will be seen in the degenerative demyelinating disorders like GBS, multiple sclerosis. So you have to rule out all this, and any unsteadiness on closing eyes, wash basin sign, and whether she is able to walk in the dark. So you have to tell about this. And Lermiter's symptom is a shock like sensation or the band like sensation on the back. It is typically seen in the multiple sclerosis. So you have to ask about the sensory system, and then you have to go with the high mental functions, like any loss of consciousness, any alteration in the sensorium. If it is alteration in the sensorium is present, you have to ask for the duration, whether it is complete, partial, and if any aura is present, any associated fits, bladder, bowel disturbances, if any seizures are present, if it is recovered or not, and what is the frequency of the seizures, you need to ask. Then go with the speech disturbances, any aphasia, slurring of speech means dysarthria. So cerebellar involvement, any slowness of the speech, extrapyramidal involvement, memory, sleep disturbances, you have to ask. And delusions, any hallucinations, emotional disturbances. So these are all higher mental functions. So you are ruling out the cortical involvement here. So in cortical involvement will be having these cortical functions: loss of consciousness, alteration in the sensorium, speech disturbances, memory, sleep, delusion, hallucinations, emotional disturbances. So rule out cortex involvement. And then go with the cranial nerves history. For the first cranial nerve, alteration in the smell. For the second cranial nerve, any blurring of vision, any diminution of the vision, whether she could differentiate the colors, any night blindness. So you need to ask, mainly blurring and diminution of the vision. And 3, 4, 6 cranial nerves, any drooping of the eyelids, any double vision is present. So you have to ask for that, any drooping and double vision. For the fifth now, any whether she could perceive the sensation over the face, and whether she is able to chew the food or not. And for the seventh now, whether she is able to close the eyelids and the lips, any deviation of the angle of mouth, drooping of saliva, able to feel the taste. So sensory and the motor, you have to ask the history. And then for the eighth now, hard of hearing, tinnitus, vertigo. And ninth and 10th, difficulty in the speech, difficulty swallowing, nasal twang to the speech, any hoarseness, any regurgitation. So these history you have to ask. And for the 11th now, whether she is able to move the neck in all directions, whether she could lift the shoulder or not. And for the 12th now, able to roll the tongue, make a bolus, and push the foot backwards. So you have to ask for the cranial nerve history. So if at all there is no history in the cranial nerves, then you have to mention in the first only there is no history. Then tell all there is no history. There is no history of alteration in the smell, blurring of vision, and diminution of the vision. No drooping of eyelids, double vision. She has sensation over the face. She is able to chew the food. She is able to close the eyelids and the lips. There is no deviation of the angle of mouth. No rolling of saliva. She could able to feel the taste. There is no hard of hearing. No history of hard of hearing, tinnitus, vertigo. There is no history of speech difficulty, swallowing, a nasal twang to the speech, regurgitation of the feet. She could move the neck in all directions, and she could lift up the shoulder, and she could able to roll the tongue and make a bolus and push the foot backwards. So you have to say like this in the cranial nerves history. And then go with the cerebellum history. Cerebellum history is mainly for what? It is for the coordination, timing, precision, movement. So this will all include the cerebellum. So in the cerebellum, you have to ask for any spilling of the food while taking the food to the mouth, any clumsiness of the hands, or any unsteadiness while walking, and any swaying like broad-based gait, whether it's present or not. You have to ask for the history. And able to negotiate narrow pathways, this is not required, I guess. So cerebellum history, you need to ask for the coordination, so spilling of the food, clumsiness of the hands, and unsteadiness while walking. Then go with the autonomic nervous system. Autonomic nervous system mainly involves bladder, bowel, giddiness, sweating, palpitation. So giddiness in the morning, it will rule out the postural hypotension. And the bladder, whether she could, so you have the UMN bladder and LMN bladder. In the UMN bladder, we have the automatic bladder, that is the patient will the patient has the hesitation to pass the urine, so there is a retention of the urine in the UMN bladder. Okay, that is corticospinal tract involvement. In LMN bladder, it is called autonomous bladder. Here the S2, S3, S4 sacral plexus are involved. So there is autonomous bladder, that is there is a rippling of urine, that is feeling of fullness of the urine is lost in the element, but its sensations are present in the UMN. So you have to rule out the UMN bladder and LMN bladder. Able to feel the fullness, it is UMN. Not able to feel the fullness, it is a LMN. Dribbling or overflow, it's a LMN. And in the UMN we have hesitation and the retention of the urine. So that is, you have to ask for that. And then any bowel constipation, loss of control, so will lead to involuntary defecation, and any giddiness on getting up in the morning will rule out the postural hypotension, sweating disturbances and the palpitations. And for the meninges, you have to ask for the fever, vomiting and the stiffness of the neck. And then go with the relevant negative history, like any trauma, fall from the height, you have to ask. And any headache, vomitings, diarrhea. Headaches will rule out the hemorrhagic stroke, and vomitings like increased intracranial tension, vomiting, diarrhea, cough, tenderness for the DVT, and chest pain for any atrial fibrillation or any cardiac embolic strokes can happen. And then drug intake like antihypertensives, oral contraceptives, anticoagulants, any vaccinations, injections. So any vaccinations or recent dog bite, for recent rabies vaccination for the dog bite, so they can all cause hemiplegia, but the etiology or etiopathogenesis is not clear in that. So you have to ask any ear discharge, vaccinations, dog bite, rabies, and history of seizures, history of trauma, and headache, vomiting. So these are all common. So you have to ask for the negative history. So in the first, you need to say the patient details, then the chief complaints, then the history of presenting illness, then describe about the weakness of the limbs, then rule out the element signs like spinomotor system, and then go with the sensory system, and then you have to go with the cranial nerves history, right? No, you have to go with the higher mental functions, and then cranial nerves history, then cerebellum, autonomic nervous system and meninges, and rule out the relevant negative history. And then you have to go with the past history, like any similar complaints in the past, transient ischemic attacks, reversible ischemic neurological deficit. Transient ischemic attack, it is less than 24 hours, like recovery is less than 24 hours, and RIND, that is reversible ischemic neurological deficit, it will take 1 to 3 weeks. So this is about RIND, or no history of TAA, ring, you have to say like that. And any comorbid conditions like diabetes, hypertension, these are all the risk factors. Coronary artery disease, thyroid, tuberculosis, HIV, malignancy, you have to ask. Any trauma, fever in the past, any drug intake or vaccinations, any prolonged illness or any surgeries in the past, any developmental history, like whether there is a delayed developmental history in the during birth. So you have to ask for this. This is about the past history, any similar illness, TIA, RIN, and then comorbid conditions, and then ask for the trauma, fever, drug intake, vaccination, previous medical illness, surgeries, and developmental history. Then go with the personal history. Personal history, as we all know, it will include the diet, appetite, bladder and bowel, addictions, and sleep disturbances. So you need to ask for this personal history. And then go with the family history, any similar complaints in the family, if at all. Then you have to say about any consanguinity present or not, and family tree, you have to draw the family tree, and any other affected family members or any other similar complaints in the family, you have to tell. And then if she is a female, you have to say about the menstrual history and obstetric history. Menstrual history, obviously we have to say about menarche, menopause, and number of children, whether she has regular, irregular, and cycles, last menstrual period, whether it was full term, preterm or term delivery, or whether it is vaginal delivery or LSCS delivery, any complications she might undergone. So you have to ask for this. Then go with the treatment history, previous treatment and present treatment. So after all this, you have to say the summary, like you have to say what is the onset, and then progression, whether it is static, improving, worsening. Then you have to say what's the disease, whether it is paraplegia, hemiplegia, multiple cranial nerve palsy or other, and structure involved, whether it is cortex, brainstem. You have to say the structure involved based on the history, whether it is cortex or internal capsule or brainstem lesion, spinal cord lesion or UMN lesion, you have to say. And then levels, single or multiple levels, and etiology. Stroke will be in the stroke, the etiology will be the vascular. So if it is traumatic, it is not a stroke. So in the stroke, the etiology will be the vascular etiology. So etiology, trauma, vascular, infective, inflammatory, degenerative, demyelinating disorders, you have to rule out. So this is about the summary. Okay. So in the history, you have to take the patient details, then the chief complaints, then history of presenting illness, then describe what the weakness of the limbs, then go with the spinomotor system, then the sensory system, then higher mental functions, then cranial nerve history, then cerebellum and ANS, autonomic nervous system, then meninges, then negative history, then go with the past history, and then go with the family history, right? Then go with the personal history or family history. Personal history will be last. Family history, then if she is a female, menstrual history and obstetric history, then treatment history, then go with the summary, whether it is onset, progression, duration, not duration, disease and structures involved, what is the etiology and what are the levels involved. So this is about the history. Then coming to the physical examination, then you have to say the general examination. Patient is conscious, coherent, cooperative, comfortably lying on the bed, and he's moderately built and nourished. Pallor, icterus, cyanosis, clubbing, pedal edema, significant lymphadenopathy are absent. You have to say like this. And then in the neck, if you notice any short neck or burns or scars, you have to say like. And in the peripheral nerves, any decubitus ulcers, tropic ulcers, you have to say. And for the peripheral nerves also, you have to examine like radial nerve, ulnar nerve, common peroneal nerve, and posterior auricular nerve. You have to check for this. And you have to say whether she is a right-handed or the left-handed individual, whether she is catheterized or not, you have to say. Then go with the neurocutaneous markers. Why we'll ask the neurocutaneous markers in the CNS case? Because they have the same origin, that is ectodermal origin. So you have to ask for the neurocutaneous markers. What are the neurocutaneous markers? You know, in the tuberous sclerosis we have adenoma sebaceum, ash leaf macules, and chagrin patches. And in the neurofibromatosis we have capillate spots, neurofibromatosis, neurofibromas, periungual fibromas, axillary flecting. In von Hippel-Lindau syndrome we have conjunctival hemangioma. Sturge-Weber syndrome we have Port-Wine stain. Ataxia telangiectasia, and spina bifida, tuft of hair. Phacomatosis, birthmarks and nevers. Friedreich ataxia, pes cavus. So you have to learn about these neurocutaneous markers. In this, the tuberous sclerosis and neurofibromatosis are very important, and you have to say like this. Then general examination, then pickle, then neurocutaneous markers, and before that you have to say about peripheral nerves and whether she is right-handed or left-handed. Then go with the vital signs: pulse rate, respiratory rate, blood pressure, temperature. Pulse rate you have to say it's a normal rate, regular rhythm, normal volume and character, felt in all the peripheral pulses are felt. There is no radioradial, radiofemoral delay, and condition of the vessel wall is normal. Then say about the blood pressure, it is 120 by 70 mmHg measured in the right upper limb in the supine portion. You have to say like that. And there is no postural hypotension. Look for any postural hypotension. And respiratory rate, whether it is abdominal, thoracic or thoraco-abdominal, you have to say. In thoraco-abdominal is seen in females, abdominal thoracic is seen in males. And temperature, whether it is febrile or afebrile, you have to say. Then go with the neurological examination. In neurological examination, first you have to tell about the higher mental functions. Same like in the history we have said weakness, spinomotor, sensory, and then we have said about the higher mental functions. Then we went for the cranial nerve. So in the same way in the examination, say about the high mental functions. High mental functions, what are they? Consciousness, orientation, speech and language, any aphasia, dysarthria, dysphonia, memory, immediate retention, recall, recent memories, any delusion, hallucinations, emotional ability. And MMSE score. In MMSE score we have 5 components. What are they? They are orientation, registration, attention, calculation, recall, and the language. So this is about the MMSE score. Okay, you need not do the MMSE score in the patient because it will take time. So you will get only the 1 hour time. So you have to write the case sheet, you have to take the history, you have to examine. So no need to write about the MMSE score in the exam. So for the higher mental functions, you need to check for the consciousness, orientation to time, place, person, speech, language, memory, delusions, hallucinations, emotional ability, and MMSE score. Then you have to go with it in the same way history, examination also in the same way. So next, cranial nerves. First cranial nerve, you have to check for the sense of the smell. With the coffee or camphor, you have to check in both the right and the left nostrils. And for the second, optic nerve, you have to check for the visual acuity using Snellen chart or any other chart. And you have to check for the visual fields by the confrontation test, and color vision by the Ishihara charts. And the fundus examination, it should be mentioned, but you have to say fundus examination is not done. Okay, this is about the second nerve, that is visual acuity, field of vision, color vision, and the fundus. So you have to say whether it's normal or not. And then for the 3, 4, 6 cranial nerves, you have to say the extraocular movements, that is H-shaped method, no? So that is extraocular movements. And then tell about the pupil size, and then do light reflex, direct light reflex, consensual light reflex, and accommodation reflex. Then say about the ptosis, nystagmus, and the Horner syndrome. So this is all about the 3, 4, 6 cranial nerves: extraocular movements, pupil size, direct, indirect, accommodation reflexes, and ptosis, nystagmus, Horner syndrome. Then for the 5th cranial nerve, it has got both the motor and the sensory. So for the sensory, you have to look over the sensations over the face using the cotton and the buccal mucosa. And for the motor, masseter temporalis and the pterygoids, you have to say you have to explain the patient like clench your teeth, so like that. This is about motor. And then for the reflexes, it's a corneal conjunctival jaw jerk. So it's efferent, no, for the corneal conjunctival jaw jerk. Efferent is a 7th cranial nerve. So this is about the 5th cranial nerve: sensory, motor, and the reflexes. What are the reflexes? Corneal, conjunctival, and the jaw jerk. If the reflexes are present or absent, you have to say whether the sensations are normal or not, they are present or not, you have to say. And then coming to the seventh nerve, it has got 4 components: motor, sensory, reflexes, and the secretomotor. For the motor component, whether there is a nasolabial fold present or not, any hyperacusis, because the seventh nerve will supply the stapedius muscle. So whether there is any hyperacusis, it is absent, you have to say if it is normal. And then occipitofrontalis, any wrinkling of head is present or not. Orbicularis ocula, whether the patient could blow his cheeks or not. And orbicularis ocula, whether the patient is able to close his eyes. Orbicularis oris, whether the patient is able to close his lips. And then buccinator, and then platysma. So you have to ask for the motor history. Then coming to the sensory, taste in the anterior 2/3 of the tongue and sensation over the tragus you have to test. And for the reflexes, corneal, conjunctival. So these are the efferent nerve supply. So seventh nerve is the efferent nerve supply for the corneal and the conjunctival reflexes. And for the secretomotor, any moistness of the eyes, tongue, and the buccal mucosa, that is lacrimal glands and the salivary glands, you have to check for the. So this is about the seventh cranial nerve: motor, sensory, reflex, and the secretomotor. Okay. Then coming to the eighth nerve, you have to check for the Rinne's test, Weber's test, and the nystagmus. And then coming to the ninth and 10th nerve, you have to check for the position of the uvula, palatal arches, and the movements, and do the gag reflex and the palatal reflex. Okay. If they are present or not, you have to say. If it is present, if it is uvula, if it is central or not, you have to say. Then coming to the 11th nerve, trapezius, sternocleidomastoid, whether stretching of shoulders is present or not, you have to check for the trapezius and the sternocleidomastoid. And then 12th nerve, whether the tone of the tongue is normal or not, wasting, any fibrillations, any tongue protrusion to the midline and the either side, you have to check all for the tongue movement. So tone, you have to check wasting, fibrillations, tongue protrusion, and any deviation. So this is about the cranial nerve history. So you have done the higher mental functions and you have done the cranial nerve history. Then you have to go with the cranial nerves examination. Then you have to go with the motor system examination. In the motor system, we have bulk, tone, power, reflexes, gait, coordination, involuntary moments. So in the bulk, you have to inspect, palpate, and then measure. In measurement, in the upper limb, you have to take 10 centimeters above the olecranon or below the olecranon, you have to measure. In the lower limb, 18 centimeters above the patella and 10 centimeters below the tibial tubercle. Okay, this is about the bulk. So write in the centimeters. Then you have to say about the tone, upper limbs and the lower limbs. Tone is a resting contraction. Okay, so you have to look for the tone with the passive flexion or the extension. So say whether it is normal, rigid, or spastic. Then go with the power. You have to check for the neck muscles and the upper limb muscles and the lower limbs. In the upper limbs, you have to check for the shoulder flexion, shoulder extension, lateral rotation, and the medial rotation. You have to check for the abduction, adduction. So with the resistance, you have to check for the power. So you need to know the power grading. So grade 1 is a power is grade 0 there is no contraction. Grade 1 is flickering of the contraction. Grade 2 is it's against resistance but gravity is eliminated. Grade 3 is against the gravity. Grade 4 is against the some resistance. Grade 5 is it's total resistance. So you need to know the grading of the power. Okay, then you have to check for the elbow flexion, extension, and the wrist, and you also have to know the muscles, what are the flexors, what are the extensors. So read about it, also the grading. And then the wrist, dorsiflexion, palmar flexion, abduction, adduction, pronation, supination movements, and the small muscles of the hand and the hand grips. So you have to write whether the power is 5/5 or not. So normal power is 5/5 against the full resistance. So you have to say like that. And then the lower limbs, hip flexion, extension, abduction, adduction, lateral rotation, median rotation, and the knee extension, flexion, ankle dorsiflexion, plantar flexion, inversion, eversion, and small muscles of the foot. Will not check, but we have to write in the case sheet. And then trunk muscles, any Beaver's sign. Beaver's sign is seen in spinal cord myelopathies, like whenever the patient gets up from the supine to the sitting position, there is a abnormal movement of the umbilicus noted. So this is abnormal because there is a lesion in the lower level. So it could be a spinal cord myelopathy. So you will see in the spinal cord myelopathy the Beaver's sign. So this is about the power. You have to check for the neck, upper limbs, lower limbs, trunk, and the any Beaver's sign is present or not. Then go with the reflexes, superficial reflexes, deep reflexes. You have to check superficial. What are the superficial reflexes? Corneal, conjunctival, pharyngeal, palatal, abdominal, cremastric, perianal, and the plantar reflex. So for the corneal reflex, what is afferent and efferent? Afferent is the trigeminal, efferent is the facial nerve. For the conjunctival also, afferent is a trigeminal, efferent is a facial. For the pharyngeal reflexes, you need to know about the nerves. And the palatal, there are palatal nerves. And for the abdominal reflexes, you have T7 to T12 dermatomes. And for cremasteric reflex also you need to know. And the perianal reflex and the plantar reflex. Plantar reflex root value is L5 and the S1. You need to strike the lateral aspect of the foot, and you need to go medial until the big toe, and you have to note the Babinski sign. Babinski sign is positive if there is a dorsiflexion of the big toe, fanning of the other toes, fanning and extension of the other toes with the dorsiflexion of the ankle, flexion of the hip, knee, and there is a contraction of the tensor fascia lata and the hamstring. So this is all about the Babinski sign. And you need to know about what is a equivocal Babinski, what is a pseudo Babinski, and what are the other methods you can elicit, like Chardocks, Gordons, and something is there. Chardocks, Gordons, and something is there. So you have to check, you have to look for other plantar reflexes, like other methods. And then you need to go with the deep tendon reflexes. Jaw jerk, both afferent and efferent is the trigeminal, and trapezius jerk and pectoralis jerk. And pectoralis and trapezius is not commonly done. And biceps jerk, root value is C5. Triceps, root value is C6 and C7. Supinator jerk, root value is C5 and the C6. And the nerve is radial nerve. For the biceps it is musculocutaneous nerve. And for the finger flexion reflexes and the knee jerk, for the knee jerk it is L2, L3, L4. Okay. And for the ankle jerk it is S1, S2 or S1. And you need to check for any clonus. So this is about the deep tendon reflexes, superficial reflexes, deep tendon reflexes, and if any primitive reflex are present or not. Normally it should be absent, like grasping reflex, glabellar reflex. So they all should be absent. And then check for the Hoffman sign, Wartenberg sign, and Rosa-Lemos sign. So these are all the other methods for the, like if there is any amputation of the lower limbs, you need to check for the equivocal Babinski in the upper limbs. So in the Hoffman sign, normally the terminal phalanx of the middle finger should be flexed, and you will note the flexion of the other fingers along with the adduction and the flexion of the thumb. So this is about the Hoffman sign. And Wartenberg sign is the patient will keep his hand supinate, and then he'll flex his fingers, and the examiner with his flexed fingers will catch the flexed fingers of the patient, and he will try to pull. Both the patient and the examiner will try to pull. And in the patient, normally the thumb should abduct, but in the Babinski sign, if it is positive, the thumb will adduct and it will flex. So this is about the Wartenberg sign. In Rosa-Lemos sign, if you contract or if you stroke the big toe of the foot, you will get the contraction of the other toes. So these are all the abnormal thing. Abnormal thing is a Rosa-Lemos sign. And what is Hoffman and Wartenberg sign? They are the equivocal Babinski sign produced in the upper limbs if at all there is an amputation in the lower limbs. So this is about the Hoffman sign, Wartenberg signs, and the Rosa-Lemos sign. And then check for the coordination. You can check along with the cerebellum, and then look for the gait. What are the different types of gaits? You know, hemiplegic gait is a circumduction gait. In paraplegia, we will get the scissoring gait, that is cerebral diplegia and the paraplegia. And the high stepping gait in the foot drop, first the toes will hit first onto the ground. So that is about high stepping gait in the foot drop. Whereas high stepping gait, that is stamping gait in the posterior column lesion, here the heel will strike first onto the ground. And then ataxic gait, this is in the cerebellar lesion. It's also called as drunken gait. It's a broad based gait. And shuffling gait is seen in extrapyramidal lesion like Parkinsonism. Shuffling gait is also called as festinate gait. And waddling gait, it is seen in the primary muscle dystrophies like lower limb proximal muscle dystrophy and any congenital dislocation of the hip. And limping gait you will see in the TB of the knee, hip joints, and the sciatica. So these are all about the different types of gaits: hemiplegic, spastic, high stepping gait, ataxic, shuffling, waddling, limping. So you need to know about the gaits. And then involuntary movements. What are the involuntary movements? You can know with the mnemonic A, B, C, D, E, F, M. A is athetosis, asterixis, balismus, chorea, dystonia, essential tremors, fasciculations, and any myoclonus. So normally the involuntary movements are graded, like they are classified into localized and generalized. Localized are the fasciculations, fibrillations, tremors, and the myoclonus. Generalized are the all these: chorea, athetosis, chorioathetosis, balismus, and then tonic spasms, clonic spasms, and then tics. So you need to know the definitions of all these involuntary movements. Okay, fasciculation is a contraction of the group of the muscle fibers or the fascicles, whereas fibrillation is the contraction of a single muscle fiber or the individual muscle fiber. So the fibrillation cannot be seen, fibrillation cannot be seen. It can be recorded on the electromyography, whereas in the fasciculations it can be seen and also it can be recorded. So this is about fasciculation and the fibrillation. Myoclonus is a shock like sensation. Okay, it's shock like sensation on contraction of the muscle, and it is arrhythmic, whereas it's tremor, it's a regular rhythmic purposeless to and fro motions of a part of a body. Okay, and they're regular. So we have the intention tremors and we have the static tremors and intention tremors will see in the intention tremors will be seen in the cerebellar disorders, and static tremors will be seen in the like Parkinsonism. So you need to know about tremors. And then so these are all about what localized fasciculations, fibrillations, myoclonus, tremors. And then generalized chorea, athetosis. You need to know chorea is a like dancing like movement. Choreographing the dancing, so rapid dancing like movement. So this is about chorea, and it is involved in the lesion in the caudate nucleus. And then athetosis. Athetosis is a lesion in the globus pallidus. And then chorioathetosis, and then balismus. They are sudden flailing violent movements. So if the subthalamic nucleus is involved, it will get hemibalismus. And tics are the rapid repeated coordinated movements, and they are to and fro movements. So you have to know all the definitions about the involuntary movements. And then go with the sensory system. So first you have did the higher mental functions, cranial nerves, motor system, and then sensory system. In the sensory system, spinothalamic, posterior column, and the cortical sensations. Spinothalamic, crude touch, pain, and the temperature. For the crude touch, you have to use the cotton. No, you have to use the pressure. You have to use the pressure with your finger or with the pen. So crude touch, pain, temperature. For the posterior column, fine touch with the cotton. And then vibration with the tuning fork, position sense, and Romberg sign. So in the Romberg sign, you need to differentiate the sensory ataxia with the cerebellar ataxia. If the patient closes his eyes and stands and if he sways on side while closing the eyes, it is due to the sensory ataxia. If he sways onto the side even on opening the eyes, it is due to the cerebellar ataxia. So Romberg sign is basically to differentiate between the cerebellar and the sensory ataxia. And then so this is about the posterior column, fine touch, vibration, position sense, and Romberg sign. And then the cortical sensations are the 2-point discrimination, tactile localization, graphesthesia, stereognosis. And then go with the cerebellar sign. Cerebellar signs you can remember with the mnemonic dashing, PTR. Dashing, D is the dyssynergia, dysmetria, dysarthria, dysdiadochokinesia, and A is the ataxic gait or the stance gait, and or the truncal ataxia. And then S is the slurring of the speech or the dysarthria. H is a hypotonia. I is the intention tremor. N is a nystagmus. G is the gait, so broad based gait. And PTR, P is the pendular knee jerk. So if you do the knee jerk reflex, and then the patient will have the to and fro movement of his lower limb. So this is for 3 times. Okay, this should exit for the 3 times. So this is about the pendular knee jerk. And then T is the titubation is the head nodding. And then R is the rebound phenomenon. So these are all the cerebellar dysfunctions, and you need to test for the coordination. What are the tests you will do? Finger nose test, and drawing a circle, putting a dot in the center of the circle. In the lower limbs, heel knee test, drawing a circle, and the dysdiadochokinesia. So this is all about the cerebellar signs. So dashing, PTR you have to remember. And then autonomic nervous system, then look for the postural hypertension, resting tachycardia, and the abnormal sweatings. So tachycardia, abnormal sweatings, and the postural hypotension. And then signs of the meningeal irritation like neck stiffness, any Kernick sign, Brudzinski sign present or not. What is a Kernick sign? In the Kernick sign, knee and hip is flexed to the 90 degrees, and then the extension will be painful. In the Brudzinski sign, with the passive flexion of the neck, patient will have the flexion of the hip and the knee. So this is about the meningeal signs. And then examination of the spine and the cranium. Look for the bony deformities, any bruit, gibbous, and the tenderness. In the cranium, bony abnormalities and the bruit. And in the peripheral And then go with the peripheral nerves examination in thickened nerves to rule out any leprosy, tropic ulcers, wrist drop, foot drop. Wrist drop is seen in radial nerve and radial nerve palsy. Foot drop is seen in common peroneal nerve palsy, and medial nerve palsy will have ape's thumb and ulnar claw hand. So you have to know about the peripheral nerves and the carotid pulses and the bruit. So this is all about the examination. First higher mental functions, then cranial nerves, then motor system, then sensory system, then cerebellum, then autonomic nervous system, then meninges and spine and the cranium, and then peripheral nerves, carotid pulses and the bruit. After all this, you have to go with the examination of the other systems. What are the other systems? CVS, respiratory, abdomen. In the CVS, you have to look for the BB, JVP, apex beat, any palpable murmurs, heart sounds, any abnormal sounds you have to look for. In the cardiovascular system, in the respiratory system, whether chest is symmetrical or not, whether there are paradoxical movements, normal vesicular bed sounds are heard or not, any abnormal or the added sounds you have to tell. And in the abdomen, you have to look for the you have to say abdomen is soft, whether there is any organomegaly and no ascites, and you have to do the rectal examination. So this is about examination of the other systems, and then you have to tell about the diagnosis. And mostly the diagnosis will be, it's a right-sided hemiplegia with human type of facial nerve palsy and involving the internal capsule of vascular etiology. So you have to say like this. And normally the patient will have all the element features even if he has the UMN lesion, because the patient will be in the spinal shock. So it will take 2 to 3 weeks to have the UMN features. So you have to say it is right-sided hemiplegia or hemiparesis. The patient will improve, no? So you have to say right hemiparesis with UMN palsy or with UMN palsy involving the internal capsule. Probably the etiology could be the vascular etiology. You have to say like that. And if it is dense hemiplegia, like if the internal capsule is involved, you have to say it's a dense hemiplegia, that is upper limb and the lower limb most commonly involved. Equally involved, that is equally involved. And which territory is most commonly involved? You have to say it could be the MCA territory, because it has got no communicating arteries, and anterocerebral, posterior cerebral has got communicating arteries. So you have to say most common artery involved is a MCA territory. And then you have to go with the diagnosis. In the diagnosis, you have to check. We have said about the provisional diagnosis, and then go for the investigations. In investigations, you have to know about the stroke protocol. In the stroke protocol, we will do some systematic examinations. So what are they? They are complete blood picture, complete urine examination, random blood sugar, serum electrolytes, serum creatinine, ECG, 2D echo, carotid Doppler, chest X-ray, USG abdomen, fasting lipid profile, CT, MRI. So this is about the stroke protocol. These are all involved in the investigations. So what are they? CBP, CUE, RBS, serum creatinine, serum electrolytes, ECG, 2D echo, carotid Doppler, chest X-ray, USG abdomen, fasting lipid profile, CT and MRI. And then if she is a female or a young male or a young female, you have to look for the other conditions like anti-neutrophilic antibodies to rule out the connective tissue disorders, any protein C, protein S deficiency like hypercoagulable states in the young males. So you have to do the investigations. So you have to know about the stroke protocol, and then you have to treat the patient. How you will treat the patient? First you have to stabilize the patient like ABC, airway, breathing and the circulation. And then you should not control the BP more than 25%, because you have you know about the Cushing's reflex, right? Increased hypertension, decreased respiratory rate, decreased pulse rate. So you need to know about the autoregulatory mechanisms in the stroke. And then you have to do the thrombolysis with the RTPA, that is recombinant tissue plasminogen activator, altiplase. It's a most commonly used, or others are retiplase are most commonly used. And criteria is within the 4.5 hours you have to do the thrombolysis. If the patient presents within 4.5 hours, you have to do the thrombolysis. And we have certain criteria to do the thrombolysis. There should be no severe hypertension, no recent abdominal surgery, no GI bleeding, no trauma, that is head trauma. So this criteria should be fulfilled if you want to do the thrombolysis. And then you have to do the secondary prevention. What's the secondary prevention? You have to give the antiplatelets, statins, and you have to treat the comorbid condition. So this is about the secondary prevention. And last resort is a rehabilitation. So first you have to stabilize the patient and then give the treatment thrombolysis, and for the thrombolysis only the CT scan is needed, not the MRI. And then go with the secondary prevention like give the antiplatelets, statins, and control the comorbid conditions. And in the last resort we have the rehabilitation, that is physiotherapy. And in all always in the treatment you have to maintain the oxygen, temperature and maintain the blood sugar levels, that is euglycemia should be maintained. In all the cases maintain the oxygen, temperature and the euglycemia, because if the patient has a fever or any increased temperature it can prolong the ischemia. So this is about the treatment part. So you have to take the history, examination, you have to tell about the provisional diagnosis and then investigations and the treatment. Thank you guys.